Good morning, everyone, and welcome to the fourth edition of the InsightHive webinars. This is the fourth of six that we've got going on. I'm Maria Moores. I work with Bridgehead Software, but before moving into healthcare technology, I spent 11 years working as a nurse. So I do know firsthand how important it is for clinicians to have access to the right information at the right time. Now, today I am delighted to be joined by fellow members of the EPR network as we explore a topic that I think many organisations have been grappling with. How do we really connect the dots between electronic patient records, shared care records, and interoperability? And perhaps more importantly, how do we make sure the information flows in a way that genuinely benefits patients and the people who care for them? We've got some fantastic speakers with us, but I'll let them introduce themselves in just a moment. First of all, a little bit of housekeeping before we get started. Everybody will be on mute with cameras off, aside from our panelists, but please do make use of the chat and Q&A throughout the session. We would love this to be as interactive as possible. So please feel free to share your thoughts and questions and experiences as we go along. The HIC team will be keeping an eye on the chat for me. And anyone who can't stay until the end, don't worry, the recordings and slides will be shared with everybody over the next couple of days. Now, many of you will already know about HIC, but for those who don't, HIC is a digital health consultancy focused on supporting transformation across the NHS and wider health sector. They're trusted by more than 70 organisations, and alongside their consultancy work, they also run the UK's only EPR network, which Bridgehead Software is proud to be a founding member of. If you'd like to find out more about HIC and the work that they do, please do reach out to them. Now, the EPR network brings together NHS professionals and supplier organisations to create a community, really, where we can share experiences, learn from each other, and tackle some of the challenges we're all facing. And within the network, there are specialist interest groups you can get involved with, and you'll see a QR code later in the session if you'd like to learn some more. The network also works with Convensis to run a number of EPR summits and events across the country. So hopefully we will see many of you in the coming months. But that is enough from me. We have got three fantastic speakers with us today, all fellow members of the EPR network, and each bring a very different perspective to this topic. So I'd like to start with some quick introductions from each of our panelists, if that's okay. So we'll put the slides away and move into what I think will be a really interesting conversation. So Amy, why don't you do your introductions first, please?
Hi everyone, I'm Amy Smith. I'm the Secondary Care Market Manager at FDB, the UK's leading provider of medicines decision support solutions. So I work closely with many of our major system suppliers across secondary care, as well as organisations in primary care, pharmacy and other specialist healthcare settings. And my role is very much focused on understanding customers' needs, supporting interoperability and helping healthcare organisations optimise safe and effective use of medicines.
Thanks, Amy. Chris, I'm going to come to you next.
Hi, good morning. My name is Chris Gillies. I work for IMD Soft, having previously worked as a nurse for 15 years in the NHS.
Lovely. And Ian?
Hi, good morning, everybody.
Hi.
I'm Ian Binks. I'm Business Development Director for Orion Health in the UK and Ireland. Orion Health are a data aggregator in England. That means shared care records. So predictably, I come at this from a space of interoperability and sharing information in the wider health system.
Thank you very much. So we've got a right mix of perspectives represented today across clinical, transformation, strategy and delivery. So let's dig in. Now, interoperability is a term we hear consistently across healthcare for the last couple of decades, I think, but it can mean very different things to different people. So let's start by unpacking a fundamental question. What does good interoperability actually look like? And are we perhaps confusing being connected with being interoperable? So I'm going to ask my first question to the whole panel. Amy, I'm going to come to you first. What is the difference between systems being connected and being truly interoperable?
Yes, it's a really good question. So I think there's quite a big difference between something being connected and truly interoperable. I think systems that can exchange data are connected, but being truly interoperable means that the data preserves its meaning, its context, and also its clinical intent. So you can move data from place to place, from system to system, but if it doesn't keep that integrity and that meaning, it doesn't help the people using the system the other side. So in our space for medicines in particular, it's not just about moving from A to B, it's about ensuring the clinicians trust and act upon the information, whether it is. So that's a really big part of, I think, keeping that data as connected as it can be in your own system, but how can you work with other systems to ensure that flows through?
And Chris, same question to you, the difference between being connected and truly interoperable in your space. What do you see that as being?
Yeah, I mean, Amy's hit the nail on the head from my point of view. It's about that data going across to another system and being relatable and usable in the other system and retaining that semantic context that we talked about. And the key thing from a clinical point of view from my end is it shouldn't create work to send that data, to have that data migrated across. It should be a smooth, safe transfer of information. We shouldn't be having clinicians having to duplicate information or work on that information again on the other side. I think, yeah, that's the key thing for me.
And Ian, from a shared record perspective, would you concur with that?
Yeah, of course. I mean, echo the other two guests' thoughts. I think connectivity is being able to see information between different systems. Interoperability is when they work together, so they actually do something together and make life easier for people. So, for example, connectivity can be a document goes from one system and appears in another and can be read. That's useful to a point, but interoperability can mean we take the structured items out of that document and we put them in a different place in the receiving system, like a DNA CPR status when you create a care plan in one document and we get a CPR status in another document. And that triggers a different way that we work with the patient without having to go and look for information.
So Chris, what do you see the clinical implications of getting this wrong could be then?
I think, as we were saying, a lot of the issues we have with connectivity as we have it now is that the information, when it does go on the other side, as Ian says, if it's a file, it has to be reread, it has to be transcribed. And from my critical care background, we have a lot of issues with that transition of care between coming from a ward to a critical care and back to the ward again. A lot of the issues there around medicines transcription, getting medications from one EPMA, which might be specific to critical care, onto the trust EPR can be challenging at times, shall we say. And the transcription process that clinicians endure causes frustration because why should you have to do it again? But also causes a risk of interruption, which leads to mistakes. So not only is it a massive time sink for clinicians, it's actually a big risk for patients. And I think that's sort of what we're seeing now as a move towards not seeing things as a digital or a computer issue, but actually the connectivity and the proper interoperability is actually a clinical risk by not having it. I think we need to sort of move our vision towards that.
So Ian, are we designing systems then around data movement or actually designing them around decision making?
That's a good question. So I think it always starts with decisions can't be made properly, right? That's always the start point. Somebody can't make a decision because they don't have the right information. But I think historically, the way we've approached the problem is that we say we need to move data from point A to point B, and then the technologists get involved, and we all say, "Oh, look how clever we are, and look what we can move." And we start to try and move as much data as we can because we can, and we solve a complex technology problem. I do think it's changing a bit, and I'm going to reference the elephant, which is the SPR here, because the way that the SPR teams are engaging with the supplier community and with the citizenry on the SPR is a bit different, because we're looking at specific areas of health and care where we know patients fall through the cracks. We know that they are complex, multidisciplinary. There's a lot of handoffs, and there are challenges. And so things like community frailty, things like maternity, those are the first two service transformation areas that the SPR are looking to resolve. And we are looking at them as areas of care, and the technology is secondary. It's how do we resolve this area of care? And then we kind of build the technology blocks that support that along the way. So I think that's how we have to approach the problem generally. Historically, it's not been like that. We've always kind of gone all in on the tech and said, let's move all the data and then unpick it later, and you just end up with noise. So I'm cautiously optimistic that that's changing.
Good. I think a lot of us are. And Amy, talking about poor interoperability in your space, how does that show up day to day?
Yeah, it's a great question, and we hear a lot of stories in between customers and NHS trusts we work with all the time. I think it shows up as friction, mainly in that everyday clinical workflow, prescribing workflows, administration workflows, discharge workflows, and so especially when moving from one system to another or between healthcare settings, as Chris and Ian have already alluded to. So I think it's things like clinicians having to re-enter meds, reconcile the differences between systems, spend time validating that information when actually they could be doing other tasks that are more important. So it's distracting them from sort of getting to that end point with a patient potentially. But I think it's really important to recognise that obviously healthcare systems in general, or any clinical system, are all built at slightly different times and for different purposes. So they're using different architectures. And I don't think the challenge is that the systems are failing. I think it's now we're asking them to work together, as Ian already alluded to, with things like SPR, across increasingly complex care pathways. I think the good news is that there is progress through standards like FHIR and SNOMED and DMD. And in our space particularly, we're looking at obviously how we always hook up those concepts to make sure that data flows through, as I've already discussed. And as we're a system agnostic supplier, we can obviously help with that middle part of everything we do. But ultimately, interoperability should be invisible to clinicians, as Chris already alluded to. And also, I think information should be simply available where it's needed. And I think that's the ambition with all of this, really.
So interoperability, I guess, isn't then simply just a technical challenge. It's about the people and the processes and the governance around it, and partnerships with the vendors and the caregivers, having that shared priority. So even when technology exists, making interoperability happen requires multiple stakeholders and organizations kind of all pulling in the same direction. So let's use that and move it into our second theme and explore interoperability as a shared responsibility. I'm going to ask the whole panel this, but Ian, I'm going to come to you first. How should accountability be shared across that ecosystem?
That's the most difficult question we've got today.
Yeah, that's why we're asking it.
Frankly, it's everybody's responsibility, and that's really challenging, because if it's everybody's responsibility, it's nobody's responsibility. Sometimes that's the case, right? If we go, everyone's responsible for this, then nobody really knows what little bit they're responsible for. But there are roles to be played by every actor in the system here. The center needs to be strong in defining standards that they want people to live up to, and then forcing that into the market. And as a technology supplier, like, that's an odd thing for me to say, because regulation and demands from the top can be challenging for us. But we have this situation where suppliers, if they don't really want to go along with standards, they just don't, and they keep their own bespoke data models, canonical data models that are really obscure and very difficult to interrogate, and then they charge lots of money to get those data out, right? So we have to get rid of that. If we're going to have true interoperability, that cannot be an operating model that anybody can be allowed to work in. So the sensor's got to be strong there. Technology providers like us, like IMDsoft, we've all got to sit around the table and say, right, well, this is the map for us to get to where technically where you want us to be, and the centre's going to need to support us with funding on that. We can't be expected to sort of re-architect our systems for free, so that has to happen. But then users need to start looking at the whole system, and that's really, really hard, because as a user, whether you're a doctor or a nurse or a social worker or a mental health provider, you're responsible for your little sphere of responsibility, and you're accountable for that, and you're targeted on that. But the only way that we achieve this proper interoperability thing is if we're looking up and down the chain and we're saying, how does this action that I'm taking affect the next person in the line? Or how is it improved by somebody else doing something differently? And being more open with each other. So there's a challenge there to kind of everybody at the coalface. How do you work differently? Because if we change the tools, that's fine. But if you don't change the way you work, it's not going to be different.
And I guess the buyers have a responsibility within that sphere as well, because a lot of the users maybe won't have a decision necessarily in the buying phase of that. I mean, same question for you, Chris. How should accountability be shared?
I mean, I wholeheartedly agree with Ian. You know, the experience that I've certainly had working in the NHS, you do get to that point where what you might want at the bedside or what you might need at the bedside isn't translated from above. I think, like Ian said, it's everyone's responsibility to look at this and to get this right. And it goes all the way to, you know, when we get to the shared care record, the regulations around the sharing of data that come from that need to be applicable internally as well as externally. And it's important to remember why we're doing this in the first place. It's not just to make a clinician's job easy, although that is a really good thing to do. But there are patients at the end of this who depend on these systems working together. And when the systems don't work together, as somebody has said in the chat already, you get incidents. And that's what we want to try and avoid. Vicariously, we'll make stuff easier for clinicians, and that's great. But at the end of the day, we need to sort of look at patient care. And that's why, you know, as Ian says, it's everyone's responsibility, that famous NHS term. I can't say any more than that, I think.
Amy, what about you? What do you see the shared responsibility being across that ecosystem? Because I mean, we've spoken about vendors and we've spoken about clinicians and patients, and I kind of alluded to it. I think buyers have a responsibility to make sure that they're understanding really what true interoperability is. Would you agree?
100%. And for me, Chris and Ian have already talked about how sort of saying this is someone else's problem all the time, like shifting it away from you isn't going to help anyone. So it's kind of, how do we bring all the stakeholders together in one room, like including the buyers, and potentially even the patients. I mean, I've seen sessions now where even bringing the patient's voice into it is really powerful. And working on it together. So it should absolutely be a shared responsibility with NHS organisations, suppliers, standards bodies, and everyone has a part to play. And it's the only way, I think, to get this aligned and sort of work a way forward with it.
Ian, have you seen examples where, and I'm not asking for examples, but where do partnerships work well and where do they break down typically when you're trying to implement interoperability?
I think so. Partnerships work well when they're driven from the user side, from the clinical side. Right? So where you have a clinical champion. So we've had areas where we've done integrations with the NHS app, where we've built kind of multidisciplinary integrated care planning, and that's only worked well because we've had really, really driven clinical champions herding the chickens. Right, so getting all of the different suppliers to the table and saying you're not leaving until you've worked this out, right? Getting NHS England to the table where necessary and just keeping it going. Where we've got just, someone says, can you connect those data? And then they just lead the two technology partners to it. That can break down. And it's not because as technology companies, we don't want it to work. It's because we don't have any guidance on how the user wants it to work. And fundamentally, there are different ways of moving data. And if we don't know what the outcome required is, then you can get it wrong. And really, we've all got lots and lots and lots of priorities. So if we don't have someone sitting there saying, this is what it's going to mean, fewer ambulance conveyances of people who don't want to go to hospital because they're end of life, or fewer falls for frailty patients. If we don't see that outcome, then that's where it starts to break down.
And I guess for Amy and Chris, for you guys, and I'm going to come to you first, Chris, how does interoperability directly impact patient outcomes? I think Ian has given us some examples there. And where are clinicians most affected by that gap in data sharing?
Yeah, I mean, sorry, excuse me. The gap that we see is when information isn't available, either coming from the community into the hospital or even going back again. Patients having to regurgitate their past medical histories. The information is readily available, but having to go through certain systems time and time again in ED or when they get to critical care or theatre or anything like that. It's those interactions with all the different systems that frustrate clinicians and certainly frustrated me. The biggest gaps we see sort of from a critical care point of view is what we talked about for meds management and getting transcription of medications from one system to another when there's no automatic transfer of information. And that's a huge area of risk and has an impact both as an inpatient and once the patient goes home as well. And what we've seen from a critical care point of view is that patients might have their medications stopped when they come to critical care, a plan put in place to reintroduce those medications, documented on their critical care system. When that patient goes back to the regular ward, not on the same system, that information gets lost. You lose information like needs an x-ray, needs follow-up, all sorts of things can get missed on transcription. And it affects patients, it affects their long-term rehab, it affects what happens when they go home, it affects what happens in the community with their GPs and their district nurses and things like that. And what can happen as well is they get readmitted to hospital. So we save money, you could say, in integration whilst or interoperability when patients are in hospital. When they go home, they come back in again. You're costing yourself money there. I think, you know, we need to look at that, as Ian says, a bigger picture of what actually happens when we don't do this right. And what happens is you have all these little issues potentially that cause money down the line. And cause patients harm as well. And it's frustrating, I think, for clinicians, like we said, to do things time and time again, to have to search this information and pull it from all these different sources, when really what we should be saying is it's all in one place, or it's all at the click of a button.
And Chris, sorry, Amy, how do you see interoperability impacts patient outcomes, and what are the gaps that clinicians are seeing from your side of things?
So I think where it has the greatest impact is definitely during that transitions of care, which has obviously been a theme throughout this already. You know, for example, at admission, discharge, referrals, and also shared care agreements, like Ian's talking about. And these are the moments where clinicians need complete and trusted medicines information to make safe decisions. So I've been in sort of, you know, conversations with clinicians where they're saying they don't even have access to the active meds that patient's on right now. So it's just those sort of situations where you can't quite believe it's happening with all this technology and the, you know, the transfer of data, but they're still not able to access very simple things that you just would assume that they have access to. So yeah, when the data doesn't flow effectively, I think clinicians are spending more valuable time verifying all those things like the history, the allergy information, and prescribing decisions that they have to make in different situations. But also where structured medicines data becomes critical, it's not enough to move, you know, that between the systems again. So hooking back to what's connected and what's interoperable and maintaining that clinical context. So I think, you know, looking at it in a more positive light, I think there's some really powerful technologies that we can start to use to sort some of this stuff out. You know, the way that some of these technologies now, you can put in a lot of unstructured data. You know, how can we all work together to pull that into one space and kind of transfer that data in an easy way while still comparing the two data sources, or whatever you want to call it. So yeah, so ultimately I think better interoperability means safer, faster, and more informed decisions for patients.
I think from my experience, sometimes interoperability, we spoke a lot about the transfer of care, failed discharges between primary and secondary care giving. I think sometimes it can also fail within the same organisation. You know, you would have a legacy system just with old data on that people don't think they need access to, but actually to have that information for the clinician. For example, my clinical background was emergency rooms, so to have, you know, the 10-year-old history of a lady that fell could have been quite valuable at that point. So I think interoperability is not just about changing care settings. Sometimes within a care setting as well, we can see a real dip in that sharing of information. I mean, Ian, from your perspective, and this is another great question, by the way, are EPRs and shared care records truly working together today?
I mean, I can answer that really quickly. No, they're not.
Please don't answer it too quickly.
That's an easy question. I mean, so if I look at EPRs, there's lots of different things. Right? It could be mental health, it could be GP, it could be acute. But let's focus on acute for a moment. So I don't think so, because acute environments are kind of by definition episodic, and it's just about dealing with that episode. How do we best deal with the episode that's in front of us in the safest way possible, quickly, using the fewest resources, and get that patient safely out of the hospital so we can treat more people in an environment that is highly overpressured. So what we do see in hospitals is high usage of something like a shared care record, because it's certainly in ED, for example, they'll pull up the shared care record to make sure that they're not missing any information about the patient, about how they treat them. But what we don't see is very good data transfer from the acute EPRs to shared care records, because deepening those integrations past things like encounters requires effort and time from hospital IT teams, which are very stretched. And they coming back to the point that Chris and I both made about kind of looking up and down the chain from away from your own environment. People don't really look at the benefit of the hospital sharing more data with the wider system. So it's never a very high priority. But if we're going to reduce things like readmissions, and if we're going to improve this concept of a more fluid delivery of care in the neighbourhood working teams, we have to share more information outside of the hospital, because we've got to start doing things like, one, that multidisciplinary integrated care planning. So people in hospitals working on a care plan that doesn't sit within their EPR, it sits in a different system that is accessible everywhere, whether it's mental health, social care, GP, because that will create, a more dynamic management of a multidisciplinary problem. But also things like risk stratification, so building comorbidity scores and then lists of patients who we have to triage differently, and we have to look after differently because we understand that they're a higher risk category. We can't do that without hospital data, because if we're doing it just on GP data, it's incomplete. If we're not accounting for hospital meds and conditions that have been diagnosed in the hospital, procedures that have happened, then we're not getting a complete picture, and it's not safe in the way that we stratify that risk. So we do need to get better. We need to get more connected, and it needs to not just be looking at a shared care record as an ancillary viewing platform to give me more information on the patient in front of me so I can handle this episode. It's got to be, this is an overlay of care across the whole system. And whilst I manage the episode in my EPR, I've got to make sure that I'm informing the rest of the system of everything that's going on, so that they don't end up back here in a week with a readmission.
So I'm going to ask all of you then, what would be the one improvement that you think would make the biggest difference right now? Amy, I'm going to come to you first.
Wow, okay. It's a really tough one, because I don't think there is like one solution. I think it's just using the building blocks we've probably already talked about. So how do we get groups of people together to build that solution? I think there's been many things that have tried to solve it but haven't quite solved it. And are we still missing tricks? Are we still missing things that actually we could be working together on to sort of consolidate a lot of this information? It's easy to sit on the outside and say, how is this happening? How is all this data just fragmented everywhere? How can we not get it into one place? But it's a huge task, and it's a mammoth task. And I don't think it's as simple. I think there's politics. I think there's collaboration. I think there's technology. And I think, like Ian alluded to, having a central kind of power on it as well, and how we move forward, and us as organizations are able to plan and help our customers and the people who matter at the end of the data. So that's kind of my opinion, but I know it didn't give you the exact answer. But
no, it's fine. That's what this webinar is all about, is just having those shared opinions and discussing them. I mean, Chris, if you could make one change to improve things, what would it be?
Well, I think we sort of mentioned it a little bit earlier on when we talked about the regulations around sharing data. And for me, whilst it might not be an easy thing to do, to say to any vendor who's supplying to the NHS, you have to provide the data or an API to that data, you have to, within the hospital, you have to do it. Out to the shared care and the single patient record, you have to do it. To say to them, without that, you can't proceed, it's a very easy thing for me to say. They might not appreciate that, but that for me would be the biggest thing. Just to get rid of that stumbling block, the very initial stumbling block that makes it the hardest when companies want to keep their own data.
Yeah, and I think that vendor lock-in is something that Bridgehead Software, we are huge advocates for having truly interoperable data where people can access the data from our clinical archive from anywhere. And it is frustrating when we see data is being locked in and trusts are charged enormous amounts of money to remove that data. And then I think there is a tendency for data, we get a nice new shiny system, we just pick up the data, move it along and put it in the new one. And there's a question in the chat here that says, should there be a single data content archive strategy? Gary, thank you for this. So 5 to 10 years of legacy data factored into an EPR program. My opinion is absolutely yes. I think it is the second best strategic move you can make behind buying an EPR, is having that legacy data within. I mean, my background when I first left nursing was to work in the radiology space. And for 25 years, people have been picking up imaging and just putting it into new different vendor archives. That can't go on. So when I entered into the EPR space and realized that the EPR vendors were not putting that data in, Gary, and then there was this space for a clinical data repository, I think absolutely that should be there to support an EPR program. And there's a great comment there that says there is one patient, there should be one records. And I think with the NHS app, that is what people are trying to do. And I don't know about, or rather that's what the government are trying to do. But I mean, I have an 84-year-old father who I've probably more chance of driving a Formula One circuit than he has of working out where his medication list is on the NHS app. I don't know if anybody else has that shared experience. So look, we've spoken about the challenges and we've explored where responsibility sits. So let's move to a final area of discussion and talk about the solutions themselves. And we've touched a little bit on that. What does good actually look like? And perhaps more importantly, how do organizations move from ambition to reality? And Chris, I think I'm going to come to you first with this question. What does true interoperability look like in the ideal NHS environment?
Well, the ideal's ideal, isn't it? I think we need to sort of think about, as someone's actually said in the chat, there's one patient record, you have one continuum of care, whether that's from a GP community point of view, through to ambulance services, through to ED, through to critical care, through to theatres, to the ward, back to home again. It should all be one thing that we can access, that we can get the whole space and see the whole space of. That's difficult, to envisage at the minute, because at the minute we've still got siloing of systems, whether that's in the GP, whether that's in hospital or not. We've still got vendors who don't want to provide access because, for whatever reason, it's more business sense to keep hold of data, to have that lock-in. So I think the ideal, you would see that all broken down. You'd see a patient-first approach to integration. You'd have the ability for patients to use an app at home that would inform clinical decisions in the future. Starting from, even doing your blood pressure or blood sugars at home, that feeds into information for your GP, using whatever algorithms they use in the future these days. It's about sort of trying to get all that together. Medication history when you go into hospital should just be there with you, as we've said already. And it shouldn't be that you, just context, Sheffield's a major trauma centre, which is where I live. And we get a lot of people who come to Sheffield for whatever reason, have an injury, their information's on a different system in a different county. We can't see it. You'd have to write to that trust, ask them to send it. It's a little bit crazy. And I think true interoperability and what we should be looking at is not just connecting to the NHS app and not just connecting to a single patient record, but actually linking all hospitals together. Very difficult because everyone has a different system. We know certain counties or certain ICBs have tried to have one vendor for all the things, but we shouldn't be looking at having one vendor. When you look at having a mobile phone, if I want to call somebody and I'm on EE and they're on O2, I can still call them. So why do we accept that, but we can't accept that all these systems should be linked together? Perhaps naively, I think that should be an easy thing to do. And
But I
you
think
know,
that's been an ambition, I think, for NHS England for many years, isn't it? Is to have everybody speaking the same language. That's why they produce the, you know, the interoperability guidelines that they have. And just to come back to my point earlier around, I think buyers have a responsibility to choose solutions that are truly interoperable, that have the fire standards, that have HIE standards, that have that. I mean, Amy, what are there examples of organizations getting this right, and what are the key building blocks for that success, if so?
Yeah, again, it's kind of, I think if you say someone's getting it right, it means they've worked out how to be truly interoperable. And I think from this webinar, we already know that's not the state at the moment. But what I can say is there are definitely organizations, you know, progressing towards that, that, you know, from a clinical and operational priority, not just a technical one. I think the common ingredients are usually that strong clinical leadership, adoption of standards like fire, DIM&D, effective governance, and obviously that close collaboration between the NHS organisations and suppliers. So at FDB, we sort of see a real success where these organisations focus on structured medicines data, and that shared kind of medicines intelligence from the outset. So we've worked directly with trusts and ICSs to support them on things like medicines mapping, and interoperability programs and terminology alignment, because obviously with our data, it's very important, especially when it's coming in for things like allergy checks and patient condition checks, that all those things are hooked up to that terminology to enable it to fire correctly as well. So yeah, we work with the suppliers very closely to ensure that these sorts of things like the selection lists and decision support, prescribing workflows can be sort of shared consistently. But I think, you know, having that middle person to help with that work, but also do it from the outset, which kind of hooks back to my point around all the systems were built at different times. So that's a tricky thing. But it's about, again, let's draw the line and say, how can we all do this together and work together on this, regardless of where your state, the state of your system or the age of your system. I think that should be sort of seen as a second thing, you know. So yeah, that's kind of my opinion.
Chris, have you got examples of where organizations are getting this right from a clinical perspective, where everything you need is there at your fingertips when you need it?
Maybe not everything, but we certainly see trusts where, I think Ian and Amy said the same thing. You have that strong clinical urge to do something, and that drive to do it, and the actual vision to do it, to then get the vendor to buy in. We do see there's a trust in Medway in Kent. They're going to link their system to their alter. No, sorry, I don't want to mention vendors, but they're going to mention the main EPR system. They're going to link two systems together. And, you know, you see it around the country. I think Wigan and Lee have got certain projects where vendors have got a buy-in. And it's about that strong clinical leadership and vendors wanting to do it. You know, that's where you see the success.
Yeah, and I think, I mean, I've worked in the vendor space for 25 years, and I don't think there are many vendors who don't want to do it. I think there is a genuine want from all vendors to do it. And I think every hospital wants to have clinical leadership, but I think in reality, and Chris, maybe you can relate to this more than the others with your clinical background, it's giving the time. It's people need the time to show that leadership, to support the vendors, to enable that interoperability. Would you agree?
Yes, without incriminating myself much, yes, in a way, no, in other ways. I think it's moving forward a little with the NHS. When I first did my digital role at my other trust, being a digital nurse is a fairly new thing. Yeah. And there was not a lot of education or structure around, you know, what do we do? What are we supposed to know? And obviously now we've got more CNIOs and, you know, CCIOs around the country driving change. That's going to filter down into individual trusts, and we're going to get that leadership coming through across all the trusts. I mean, we probably already do, and I probably just don't know everybody, but I think that's what we need to get to. It's just that awareness of how things are meant to work. Like Ian said, if the trust doesn't know how they want it to work, how's the vendor supposed to know? And I think we're going to get to that point now where trusts are going to be more clued up to what they can ask for and what they should ask for.
Yeah,
Lovely.
definitely. I kind of agree with that, Chris. And also, I think the other thing I miss, Maria, is I think the organisations getting it right aren't trying to just solve it all at once. They're like going,
Right.
this is too complex, let's take these really practical steps to build towards that sort of more connected future and how that works. So you can't solve it all in one go, but how do we do a staged approach to get there?
And that must be a long program, right? That requires investment, and I guess getting that investment is another challenge that they have. These things are never easy. Ian, I'm going to come to you with some questions, but please keep putting your questions in the chat, because we're going to be how do you eat an elephant? One piece at a time. That's exactly right. Please put your questions in. We're going to be coming to you in a second. Ian, do you think we've overcomplicated solutions, and how do we avoid overcomplicating them if we have?
So I'm in danger of being slightly provocative here, right? Nobody likes anything that's overly complicated. But I think I'm more worried that we try to oversimplify the problem. We have to accept that this concept of true interoperability that we're talking about here, the ideal that we want to get to, is a wicked problem, and it has a huge amount of complexity to it. And there is a difference between complex and complicated, right? So we'll separate those two things. But if we're gonna make serious gains in this space, then I think we have to roll our sleeves up and deal with the fact that we've got a complex problem and we need a complex set of solutions to it, and not try to oversimplify that. And I think historically, as you mentioned, Maria, right, the NHS England, the Centre, the DHSC, right, have been trying to solve this problem for a very, very long time. I remember Tony Blair talking about, fall over in Brighton and your records in Birmingham or whatever, and everybody should see the same thing, right? I think it was Bradford, actually. But anyway, this has been a problem for a really long time, and we've tried to solve it. The issue we have is the NHS is inexorably tied to political cycles of 5 years or less, and change must be rapid, and nobody wants to stir the pot too much, so we try and oversimplify things, and we never ever get where we need to be. And I think so much stuff just ends up in the too hard bucket. It's like, oh, we can't deal with that now, it's too hard. We can't deal with that now, it's too hard. If we want to deal with this, somebody's got to get in that bucket, start pulling things out and start fixing them. And that's difficult, and it is complex. And I completely agree with Amy's point. We have to do it bit by bit. We have to look at where we can make gains and make progress, and that can lead to more progress, and that can lead to more progress. But that has to be based on a roadmap of it gets us to this, promised land.
So is that roadmap, that's an interesting point, is that roadmap the responsibility of the DHSE or the Department of Health and Social Care to roll out to organisations to say this is your roadmap? Or is it the responsibility of individual trusts or GP practices or mental health trusts who should have their own roadmap? How should you tackle that? Should it come from the top down? And yes, we do have strategies coming from the top down, but do we have one that truly underpins interoperability, do you think?
I don't think we do, but I think
I don't believe we do.
It's somewhat linked to the lofty goals of the single patient record, but I can see it happening with the SPR already, right? The ambitions and the drive of the SPR being scaled back and narrowed, and we want to do this first and then this and then that, and that's in some ways the right thing to do because it means progress can be made. But it maintains a roadmap. But I do think the direction needs to come from the centre, because the centre needs to mandate to organisations that don't really find priority in reorganising their data structures or setting up proper APIs to exchange data, that has to become part of their priority, or they will find it difficult to operate in this market, because otherwise we are always in the too hard bucket.
Yeah.
Just not going to get out of it.
Yeah. Okay, let's move on to some questions, unless Chris or Amy have got anything else they wanted to add on that topic. I'm going to quickly have a look. So, as discussed, interoperability and data quality are two sides of the same coin. We can move data between systems, but ensuring it is complete, consistent, and systematic aligned is harder than the problem. Where do you think the biggest impact will come from next? Better data standards, improved governance at source, or stronger data quality tools across systems? That's a great question. So where do we think the impact is going to come best from when we're talking about interoperability? Is it better data standards, improved governance, or stronger quality tools across the systems? Chris, I'm going to come to you.
I was still trying to absorb the question.
I know, it's a great one.
I think with interoperability, I think you see benefits in all those areas. You know, it's not limited to one particular section of getting it right. I found the question now.
So it's around data standards, yeah.
I mean, like Amy was saying, having the coding for drugs and things like that is key to all of these things. The issue we've got with particularly with NHS things, and I might be wrong, so someone can correct me, is I don't think we code things like this is your diagnosis from critical care, this is your operation thing from theatres. So to go from one system to another, are those things linked properly yet? I don't know if they are. So we do things like drugs, but stuff that's like text-based, I don't think we do a lot of connections with that. So text just becomes text becomes text.
I think with the data standards, if I can just come in on this question, I think we've got the right data standards. I think FHIR as a data standard, as an interoperability standard, is amazing, and it's something that we work in all the time. Amy, I know your system is FHIR. Ian, I'm assuming we all do FHIR. It's just to get that FHIR component into the data to make it interoperable is hard work. It's much easier to take data in a different format because it's much quicker to transpose. So I think it's not necessarily improving the data standards, it's improving how we get there, I think, possibly. Would you agree, Ian or Amy?
There's a difference. Yeah, sorry, I was just chipping in there.
No, go ahead.
There's a difference between obviously messaging again between two systems and then it being able to understand the data. So you might be able to send it with your nice FHIR compliant wrapper,
yeah.
But once it gets to the other system, is it going to be able to process and understand that? And I think that is still, you know, is that data quality, is that data standards? I think all three of those are sort of separate problems in their own right. But again, it's down to those different systems and how they take in things, the architecture, everything, and you know, from the start to the end journey, what happens. And I think it was Andy Miner, he said about that stat, when data gets transferred from two different systems, there was a study that showed that you could lose up to 60% of patients' data. But if you have it between the same system, you could still lose up to 40% of patients' data. So it's not even happening between different systems, it's happening within the same system, as we've already kind of alluded to as well. So yeah.
So there's a great question here, Ian. I'm going to ask you this question. So this is from Stefan. As a counter argument, does the piecemeal approach to solutions just add to the fragmentation and interoperability problem?
Absolutely, if not done correctly, right? So, and this is why I talk about there needs to be an overarching roadmap of how we get to where we get to, because it's yes, you know, you do eat an elephant one bite at a time, but you know what the elephant is from the start. So you can see the elephant, and the point here is that if we approach it just if we approach each problem individually in isolation and try and solve that problem, that's where we end up with this non-connected patchwork of really good solutions to individual problems that don't solve the whole problem or even make it worse, right? Because and it comes to the point, you know, Amy just made about how if we try and move data between those systems, do they understand them in the same way? Do they consume them in the same way? Can they present them in the same way? So are we losing clinical meaning when we're transferring data? So I think the piecemeal approach is really dangerous if it is not guided by one fully thought out vision of how things should work together. Because otherwise, you know, you've got like 10 different jigsaw puzzles and you chuck all the pieces together and you try and build one picture, it's not going to work.
Absolutely. Amy, did you want to come in on that at all?
It was a really, really great point. And obviously I'm coming at it from very much a medicines dosing angle. So the drug being transferred, the dosing being transferred. So I think when I'm talking about organizations that have got it right, they've obviously gone, right, we're going to sort out our meds and then we're going to create a structured dosing to then send out. So they've done it in that kind of road mapped way. But this is bigger than that. This isn't just about medicines. This is about everything and all the data that gets transferred. So, and I think what Chris said was really spot on about the data quality again. Things like being like coding in secondary care is still like immature compared to primary care, for example, because they haven't necessarily got the structure and the data to do so, and even the time. Where do you fit that into your day, like being able to code these things? So it's a full circle problem a lot of the time. I think.
It is and as we said, it's in the too hard bucket, isn't it, sometimes? So we need to tackle that. We've got a question here from Yvonne. She says, I think a reflective question is, what do we really want from having a digital system? What are the requirements? Enterprise health information systems should meet certain requirements if the roadmap requires organizations to be digitally mature as per HL7. HL7 standard is probably one of the oldest standards going, and the reason it's there is they never did an HL8 or an HL9. They just did an HL7 V2, didn't they? Because it was so good, everybody just sort of learnt it. And I know for the last 20 years we've been on HL7. But what are the requirements of a digital health system? What enterprise health information should meet certain requirements. But I think, again, this maybe comes down to the buyers, not just the people who are writing the specification, but the people who are making those final decisions, really listening to those key voices within the clinical space that tell them what they need. And it's about outcomes as well. It's not just about, I think sometimes we can focus on what do you speak? Do you speak fire? Do you speak open air? Do you speak DICOM? Do you speak HL7? Actually, I think buyers should be asking, what is the outcome you are going to give me for my patients with your solution? What outcome are you going to change for me? Or these are my pain points. Help me understand where we need to go. So, Ian, I mean, it's a great question. What do we really want from a digital system?
So it is a really good question, and it's a little bit philosophical, I suppose.
Yeah.
But so you can take it right back to what's the purpose of all of it? Are we looking to have a healthier population that is more proactively managed than reactively managed, fewer acute episodes of care, or are we looking to manage episodes better when patients deteriorate? Because at the moment, hospitals are designed to manage episodes really well, and GPs are designed to manage long-term health well, and treat minor deteriorations before they turn into major deteriorations, and mental health are designed to treat mental health issues. If we're looking at digital systems and this true interoperability, what is our purpose? And I think our purpose should be a healthier population, right? And in which case you've got to work back from that before you get to any of the questions about fire or HL7 V2 or DICOM or any of that question. Why are we building this system? And nobody, I don't think there's agreement on that. I think, broadly speaking, everyone would say we'd like to have a healthier population that doesn't deteriorate to ill health. But I'm not sure if you asked hospital executives if that's the problem that they're trying to solve. I don't think they would. So I think the system needs to be more joined up in what the purpose of these questions are.
Do you think, so there's a question here, so do you think that there is knowledge within and the skills within those organizations to make the right decisions? I mean, I've certainly come across hugely capable people in the NHS, I think, are making absolutely the right decisions. And I think that the workforce does get more engaged in those procurement, certainly those pre-procurement exercises where they're starting to look at what outcomes are we trying to achieve. Okay, I want to buy a system for critical care, Chris. You must have the workforce engagement coming from there, from the clinicians, about what it is that they need. So I would say that the skills knowledge is absolutely there in the NHS. I think the question could be, are they utilising it right, or giving them the space to be able to engage there correctly? Are they? Because I think there is so much pressure there.
Yeah, I think the skills are coming in, and like I was saying before, digital nursing and certainly digital in a clinical aspect has come into its own. over the last 10, 15 years, and there's more stuff going on. I think what can happen is even when you have those people in those positions, there is still the hamstring of finance and money, and you might want an ideal system, but you can't have it because of X, Y, and Z. And I think I've just forgotten what I was going to say now. But one of the other things I was going to say was really important and really fascinating, and I've lost it.
We were talking about skills and if they got the skills, and we were saying that they absolutely do have the skills. It's whether or not they have the capacity to engage with those.
And what I was going to say, just to come back to one of Ian's points earlier, is it's fair enough, and I think one of the comments in the chat is it's fair enough, a trust having an idea of what it wants, but nationally we need to have the idea of what we want. And just going back to some of that Ian was talking about, the cycle of government, and this is really, very out there, but is there not a time in place to have a non-governmental body running policy in the NHS, to sort it out? And, it'll come down to funding and how do you fund these extra ones. But then you're going to talk about having NHS England back and NHS X and all that sort of stuff. So, we always reinvent the wheel in the NHS, and I think it will come back round to that. We'll reinvent this wheel again.
Possibly.
Ian,
Slightly did you want to come in?
Controversially, just on the point of skills and knowledge, I'm just going to poke the bear a little bit here. An enormous amount of institutional knowledge is just leaving the NHS right now, not by choice necessarily, because of the redundancies, especially in ICB land, right? So 50% redundancies. There are a huge amount of highly knowledgeable, highly talented people who are leaving, and it's a worry. Like, where is that knowledge gap going to be plugged from?
Yeah.
I
Guys,
just saw a really interesting last point in the chat.
Go ahead, Amy.
And it was where my brain was going. Like surely the only way to solve this completely would be to have one system to rule them all, which just sounds quite sort of scary. But obviously that's talked about a lot, and it's a theme throughout many sort of conversations around interoperability. But I think it's just hooking back to what does that then do, to the wider landscape. Innovation is potentially being stifled if you don't have other players in the market and other systems that are doing different things. But it's a really, really good point. If you have the same system built from the ground up in every area, of course it's going to solve it, but that's just a utopia, isn't it?
Listen, this has been such an interesting conversation. A huge thank you, Chris, Amy and Ian, for sharing your insights and experiences. And thank you to everybody who's been joining in the chat and contributing through the Q&A. We will have a look at your questions after the webinar is closed. First of all, just a little talk about our special interest groups. Our special interest groups are free to NHS colleagues. So if today's discussion has sparked ideas or challenges you would like to explore further, I would really encourage you to get involved in the EPR network and their specialist interest groups, where these conversations continue throughout the year. We've got maternity and neonatal. Paper to digital is hugely popular right now. Of course, there's an AI one, there's a pharmacy one. I know, Amy, you're engaged in that one, and these just named just a few. They are chaired by and attended by NHS professionals, so it really is you guys coming together and seeing what works. Here is the QR code if you're interested in joining the summits in each of the regions of the UK. Hopefully we will see you in person at one of these events. And once again, they are free to NHS staff to attend. The HIC team will be sending a recording of this webinar, the slides and the follow-up resources within the next 48 hours. So please keep an eye on your inbox. Thank you again for joining. Amy, Ian, Chris, thank you for your time. Enjoy the rest of the day, and we hope to see you at a future webinar or regional event soon. Thank you very much, everybody.
Thanks, Maria.
Thanks all.
Thank you.
Thank you.
Bye.
Bye.